Thank you very much, Richard, for those warm words, and thank you all for being here. I felt very fortunate in 1993 when I was the chief economist of the World Bank, and actually in 1992, and had the responsibility of setting the agenda for the next World Development Report at a time when the bank's emphasis was very much on structural adjustment, on the virtues of various kinds of economic liberalization and privatization. It seemed to me that it was appropriate after several years when the virtues of those policies had been explained at substantial length by the bank, that it was appropriate to do something different, to emphasize a sphere in which a more effective public sector could make an enormous difference, and to emphasize a sphere in which the returns were pecuniary, but in which there were also very substantial non-pecuniary returns. That it was important also for an institution like the bank to highlight that rigorous economic reasoning could make an important contribution to addressing the most morally significant issues. And so I judged that it would be a good idea for the bank to devote its World Development Report to investing in health. And having made that judgment, it was a relatively easy judgment, though not one that was entirely without controversy within the bank, to select Dean Jamieson as the team leader. And my faith in Dean as a person who could live by a doctrine that I had enunciated often as chief economist of the bank, that you have not said something meaningful unless a reasonable person could possibly disagree with it. Dean certainly achieved the statement of meaningful propositions according to my standard. I am proud to have played a small role in catalyzing that effort and all that followed from the World Development Report, which is not to say that all that it said looks precisely right with the benefit of 20 years hindsight. It was Darwin, I believe, who stated that a good argument, factually supported, whether ultimately verified or ultimately not verified, contributes very substantially to human progress. And so I was delighted, more than a little bit, flattered and honored when Dean suggested to me that he and Richard Horton and the Lancet and the substantial global health community that looks to the Lancet felt that a revisiting of our report would be appropriate, and that I could make a contribution by serving as chair. I was under no illusion that I possessed the specific expertise that many of the other participants did possess, and indeed I found out very quickly how far the field had advanced and how little I knew. But I felt I could make some contribution in guiding the discussions and thinking about how the global health report could reach a broader community beyond those whose everyday preoccupation was with global health. And frankly, I have to say that as the Commission did its work, I came to be deeply impressed by the magnitude of the opportunity that is before the world over the next generation. If one thinks about the broad sweep of human history, the broad sweep of human demographic history, for the vast majority of human history, health status, life expectancy, child mortality rates were relatively similar everywhere. Child mortality rates were high, life expectancy was short, health status was poor. And that was the universal condition of man until some moment, perhaps a couple of centuries ago. Then, with some combination of scientific progress, greater public awareness of the needs of all, improved public health measures, scientific progress in treating particular disease, and the dissemination of that progress, one saw a great divergence in health status among the nations of the world, to the point where child mortality rates differed between the most successful and the least successful nations by a factor of 30 or more. That was the situation when the World Development Report in 1993 was written. There was very substantial progress at that time to chronicle over the previous 2 decades, and there was very substantial progress to look forward to. But what is remarkable about this moment is that with respect to the major traditional afflictions of man, reproductive, maternal, and child mortality, and infectious disease, it is now within reach, within a generation, to achieve very substantial global convergence. One way of stating that is to observe that it is possible to imagine, with a program laid out in this report, that child mortality rates in low-income countries and lower middle-income countries will decline to essentially the level that they had reached in the United States or Great Britain in 1980, well within the lifetimes of most of us in this room. The report emphasizes a different comparison, the capacity to achieve universally the levels that had been reached in some of the most successful middle-income countries, what we refer to as the 4 Cs, China, Chile, Costa Rica, and Cuba. However you state it, this end to tremendous divergence, this reconvergence, this time at a high level, has the potential to be a once in human history achievement. And if one takes one message away from this report, it is that unique opportunity that is open to this generation. Let me highlight several other messages that are most important to me, and then turn this to a general discussion of major themes before we get to the more specific analyses. First, the report advances further the discussion that was an important theme in the World Development Report and a central theme of the Commission on Macroeconomics and Health sponsored by the World Health Organization under the leadership of Jeff Sachs in 2001. Namely, that successful health investments have an enormous payoff. Much of that payoff is direct and instrumental. Individuals who are in better health work better, work longer, work more successfully. Societies with longer life expectancies find themselves choosing to save and invest more than societies with shorter life expectancies. Societies with healthier children produce more productive next generations of workers. And on that, the evidence continues to come in ever more strongly. There is, though, a second aspect, an aspect that is, at one level, slightly more abstract to economists, but is, at another level, more concrete and more human. And that is that quite apart from any instrumental value in terms of increasing productivity, individuals want to live longer. They show every day that they are prepared to pay to live longer, that they accept lower wages to take safe jobs, that they pay more for safe cars, and the like. And so it is possible, and this is where economic research has advanced considerably over the last couple of decades, to put a dollar value on the direct value of greater survival. When that is done, it substantially increases the estimates of the economic return to healthcare. Just the direct benefit of healthcare, of the value people place on survival, apart from any direct measure, accounts for a value equal to about a quarter of the economic growth in the developing world over the last 2 decades. That is a remarkably high figure for a sector where public expenditures typically represent far less than 5% of GDP. Or to put the implication in a different way, once these values are recognized, the grand convergence program that the report outlines has a benefit cost ratio of between 9 and 20, depending on which part of the developing world we are emphasizing, we are looking at. Let me say that again. A $1 investment yields benefits valued at between $9 and $20. Now, I've spent most of my time in the financial sector and in one way or another involved with finance. And it is true that if you were smart enough to invest with Mark Zuckerberg early enough, that you would have earned a return considerably greater than 9 to 20-fold. But at that moment, no one could have foreseen that return. In financial markets, in contemporary capitalism, investments with foreseeable returns of 9 to 1 or 20 to 1 over reasonable horizons do not exist. This is not a high-risk venture capital investment that might turn out. This is the replication of models that have succeeded in large parts of the world with a payoff of between 9 and 20 to 1. So first major conclusion, the economic returns to health investments are substantial and greatly magnified when you recognize the value of a life. Second major conclusion, and this I already talked about, grand convergence is attainable within a generation before 2035. The benefit of achieving that agenda is 10 million lives saved each year beginning in 2035, and obviously millions of lives along the way. The saving of those 10 million lives, or the averting of 10 million deaths a year, comes at a cost across the developing world that is eminently payable. That cost, the Commission estimates, is $70 billion. $70 billion represents less than 1% of the extra GDP that will be available to middle-income countries and lower middle-income countries and lower-income countries in 2035 as a consequence of increased GDP growth. 1%, 10 million deaths averted. Now, because Dean and Gavin and the other commissioners are very careful scholars, the report is more careful in its statement than I just was. It separates lower-income countries from lower middle-income countries. And as you might expect, most of the economic growth is in the lower middle-income countries. And so if one looks only to the lower income countries, we are talking about a number that approaches 3% of GDP to save 4 million lives. Now, what follows from this is that in large parts of the world, indeed in the middle-income country category, where a majority of the improved health is possible, because that is now where a majority of the world's poor live, the resources for direct service provision can be mobilized from domestic resources. I will come back to the role of the international community in a moment, but I want to underscore that part of the evolution here is towards an increasing part of what needs to be done for a substantial part of the world being doable within middle-income countries. Now, success always breeds next challenges. If, as we hope, expect, and pray, the world is successful in achieving this substantial convergence with respect to maternal and child health, and with respect to infectious disease, then it is natural to expect, and indeed it is certain, that the health challenges of the developing world will increasingly resemble the health challenges of the industrial world. That's, after all, part of what convergence means. And that means that issues associated with chronic and non-communicable disease will come to be increasingly important. The report emphasizes the very large role with respect to broad public policy measures that address these issues on a population scale. If you remember only one statistic in this area, remember this one. A 50% tobacco tax over the next 50 years in China will raise $20 billion a year, an amount that can make a substantial contribution with respect to health, and will save 20 million lives by averting 20 million premature deaths. Reducing tobacco consumption is the single most important step that can be taken to reduce chronic disease burdens. Report also emphasizes the importance of similar measures with respect to alcohol, emphasizes that an area for major exploration with respect to the use of tax, price, and regulatory instruments over the next generation will be with respect to diet issues that contribute to obesity, and underscores the importance of environmental improvements, and in particular, the reduction in fossil fuel subsidies. Here, there is a substantial difference between the issue as it presents for the industrial countries and the issue as it presents for many developing countries. In the industrial world, the main reason to reduce fossil fuel consumption is to prevent global climate change. That is an equally important reason in the developing world. But in much of the developing world, reduction in fossil fuel consumption also makes a direct and immediate contribution to human health by improving the quality of the air that is being breathed within hours of when those fossil fuels are burned. There is also clearly a case for an expanding menu of clinical interventions with respect to chronic disease once it has arisen that the report emphasizes. The report also takes up issues that generated very substantial controversy associated with, I just got the signal, with WDR 1993 around the movement towards universal health care. And it, of course, underscores the importance of universal health care as a universal goal, and argues for a strategy of pro-poor universalism. It is, I think, fair to say that it is substantially less enthusiastic about user fees than WDR 1993 was, though it recognizes that in environments where resources are constrained, choices have to be made, that not everything is possible, but emphasizes the importance of broadening the package that is made available, and it within state systems, and emphasizes in particular the importance of universal financing of those interventions that are most important for the poor. Finally, the report highlights the importance of the efforts of the international community. It recognizes that the international community will have a continuing role in financing the basic delivery of services within low-income countries. It recognizes that no transition in this field, given human consequences, should ever be too sharp or abrupt, even as it calls for increased national efforts in lower middle income countries. But the primary focus, or the one that seemed most important to me, was the report's emphasis on the need for the global community to do more with respect to global public goods. There was universal consensus in the Commission and on the part of those experts that we consulted that a doubling of R&D budgets from $3 to $6 billion would have very substantial benefits, that these were not speculative, that one could be quite confident that substantial increases in R&D would produce very substantial and concrete benefits. There's a tendency when one thinks about medical research to envision biological scientists in laboratories with test tubes and assays, and that is essential. But the report also emphasizes the very substantial scope for research in what might be called implementation science, the identification of the most cost-effective modes of treatment in different kinds of environments. We also emphasize the importance of other sources, other kinds of efforts with respect to global public goods, consideration of immune responses to treatments for infectious diseases are one example. Perhaps the example that seemed most powerful to me went to the question of pandemic risk. I knew before I was involved in this report that the flu pandemic of 1918 had killed more than twice as many people as the First World War. I did not know until I became involved in this report that the World Health Organization, the principal agency we look to for global security with respect to this issue, had an influenza budget that was less than that of New York City. And that, I would suggest, is imprudent in the extreme for the planet as a whole. Let me finish where I began. This is the next report that has been written on global health. It will not be the last. There will be challenges for as long as anyone can foresee. But we do stand on the brink of what is a once in human history opportunity the achievement of substantial convergence for peoples everywhere on this planet with respect to what is most important to them, their health. We can afford it. We know how to do it. The challenge is getting the job done. Thank you very much.